I am Noelle Carlozzi. I am a professor in the Department of Physical Medicine and Rehabilitation. I also have a joint appointment with surgery, and I have an appointment that just started with ISR. This is sort of like my first foray into behavioral just-in-time adaptive trials. This is really a micro-randomization trial that I'm going to be talking about. And they asked me to talk to you guys today about sort of lessons learned. And I'm going to start with, if I were to do this study again, I would do it completely differently. Like, there's very little that I would do the same. So I definitely learned a lot. I'm going to sort of present by sort of going through the process that I went through and sort of, how we set up the study, what our results are, and then insert expletive here. This is not what we were expecting to find. Like, what happened here? And then we did some qualitative work to sort of get at some of these issues and some of the surprises we saw in the data. And hopefully I can share some of these tips with you, some of which you probably already know if you're doing this type of work, and some of which may be new to you, but hopefully to minimize how much people reinvent the wheel each time we do this type of work. Okay, let me advance. Doesn't want to advance. There we go. So, JITAIs, really the goal here is to figure out the right amount of support for the right person at the right time. There's a lot of data from other populations around using JITAIs to increase physical activity, decrease drinking, for smoking cessation, and to improve mood. And sort of when we first started thinking about this study, I was doing work in care partners, specifically care partners of people with traumatic brain injury. And I heard about Srijan's work, actually, and that he was doing this cool sort of push notification JITAI system. And I was like, wow, wouldn't it be really cool to do this in a care partner population? They're a really burdened population. They have a lot of stress, a lot of strain, a lot of sort of negative outcomes. And this is a low touch type intervention, right? If we can maximize what we do for people, tailor it, target it, we can hopefully get more bang for our buck with less time investment on sort of the care partner side. And we also know with care partners that you're sort of only, your well-being is directly related to your care recipient's well-being. So we know this from research already, that if care partners are doing crappy, essentially so is the person that they're providing care for. So that relationship is a reciprocal one. And so improving one side of the dyad should presumably help improve the other side of the dyad. So this study was really designed to look at the efficacy of a JITAI. And I'm using JITAI. This is actually really the micro-randomized trial that would inform a future JITAI. So it's not really, it's kind of a simple, stupid JITAI in terms of its methodological framework, because we would use this to actually do a more personalized, tailored intervention later. But is really around improving outcomes for these care partners and trying to figure out who's at the greatest risk. And you're going to see on some of these slides, these little red herrings. This is the foreshadowing of some of the lessons learned. So you're going to see the red herrings now, and I'm going to talk later, a little later in the presentation, about sort of what these red herrings represent. But just to sort of orient you. So every time you see a red herring, there's a problem. So there's a lot of problems. So we did a randomized trial of 240 caregivers. Everybody did a baseline assessment. It's fully virtual. So people we contacted people. We enrolled them over the phone. We sent them a Fitbit. We had them sort of engaged with the app, the TBI CareQual app, which I'll show a picture of in a few slides. They answered daily questions about their mood each day. They answered end of month surveys that were sort of a longer battery of health related quality of life assessments. They wore the Fitbit for 6 months. And then the group that was randomized to sort of the JITAI intervention also got push notifications that were informed by the Fitbit data and the self-report data that was being collected during that 6-month period. The end of 6 months, study ends, and then we did a 3-month follow-up and a 6-month follow-up here. So I'm a PRO researcher, a patient-reported outcomes researcher, so we gave a lot of patient-reported outcomes. At baseline, basically at baseline at the end of the month, we gave the same sort of battery of HRQOL tests. And then the daily assessments were single item assessments, 1 item for caregiver strain, 1 item for anxiety, and 1 item for depression. And these items were administered as a computer adaptive test that was given a single item over the course of the week. So a computer adaptive test is a smart test that chooses the next best item for you based on your previous response. So kind of like the math section of the GRE, or at least historically, this is how the math section would work. Get an item right, you get a harder item, you get it wrong, getting a user item, and the test stops when it figures out sort of what your math ability is. So we were administering these PROs in sort of this innovative way where they got a single item each day, and then at the end of the week, it sort of reset and started from scratch. We also did sort of check-ins for adverse events and med history. At the end of 6 months, we asked about sort of their experiences with the study. And then we did the 3 and 6 month post follow-up visits. So the app itself, I probably really should have a few red herrings on here for this. So we built this mobile health intervention in collaboration with Arbor Moon, who is gone. They went out of business. Red flag right there, right? Your app company goes bankrupt during your study. Not ideal. But the system itself includes sort of these 2 components, as I mentioned. So the self-report ratings and Fitbit data. Just getting my... So here is sort of the self-report scores for the PROs. So each day, it looks very much like what you would see in a Fitbit dashboard, right? So everybody gets the dashboard. They see their sleep, they see their steps, they see their scores on these PRO surveys. And then they also have activities. So this is where it tells them when they last sank the Fitbit, if they completed the daily survey, if they're in the intervention group, they get a message to improve their overall well-being, and that shows up here. And if there's pending surveys, so those end of month surveys, they show up here, and this is their completed survey. So everybody gets this dashboard. This looks exactly the same with the exception of this most recent message, which only I'm going to call it the intervention group right now, receives. So those that were in sort of the intervention arm, they received prompts that were really focused on improving healthy behaviors or mood. Each day there was a 50-50 chance of receiving a prompt. Most of the prompts included feedback. So it would, say your average rating of X was this. Try doing this to improve whatever the domain is. It might include facts or tips, or just sort of general support. And this is an example of each item. There are red herrings on here, so I'm going to come back and talk a little bit about these prompts themselves. But really, there were very subtle differences in how we sort of did a low, medium, or high level prompt. So, basically the idea here is if you're getting less than the recommended amount of sleep, you should get a stronger suggestion to work on sleep. If you're getting sort of an average amount of sleep, they might still give you some tips and recommendations, but it shouldn't be as strongly worded as the low example. And if you're doing a good job with sleep, it should really just be keep up the good work. If you ever have problems, you could try doing something. So these are very subtle distinctions, and you can see that in the examples on this screen here. But the level of the prompts always based on their data, either for the past week or the past month, depending on what that example question calls for. So if you the way the randomization works for these prompts is it randomly selects a prompt for you. If you have the data for it, you get that. If you don't have the data for it, it randomly selects another one until it finds one that has the data for it to sort of give you a prompt. And then we ended up having 118 people complete each study arm. And, you know, we really had very, very high rates of retention in this study, and that's partly because we incentivize them. People got $1 a day for providing any data, so either filling out the self-report surveys or syncing their Fitbit, they would get $1 a day. They got a little bit more incentive for completing the end of month surveys. The 6-month time point was our primary endpoint, so we made sure that study window was large enough, and we did a lot of reminders to make sure we got them in, because we would have to replace anybody that didn't complete that 6-month visit. But we had pretty decent retention in this study. We didn't see differences between the two groups sort of on demographic variables, which meant the randomization works. And this is sort of what our general complicated, mild, moderate, and severe caregiver groups tend to look like. So we didn't really have like that. This sort of matches the type of people that we generally see in these types of studies. Okay, so protocol compliance, we had really high compliance. So these are reported as the percentage of days with data over the number of days in the study. And so like ranging from 72 to 82% for this daily data. I mean, this is over 6 months. That's really quite good. It's much higher than I think what we tend to see in other studies that have this daily monitoring type of component. And I would really attribute this to sort of a couple of things. We would give them a reminder if we didn't see any data in over 3 days. 3 days of missing data, we reached out to them in some way, via email, via phone, and we would follow up. And we were pretty persistent in that. So once we started to see missing data, we were bugging them to fill out data. And I also think sort of the incentives that were provided were enough to sort of keep people filling things out. In terms of our end of month surveys, these are even higher. The incentive for this was a little bit higher. We also had reminders once the study window opened for them to fill it out. And if they didn't fill it out, we were calling to follow up. And so you can see like, the lowest completion rate here is 94%. So we did a pretty good job with that as well. Okay, but that being said, when we looked at the data, and this is just for the first 6 months, these are our different outcome measures. So caregiver strain, depression, anxiety, these are the monthly scores. The yellowish line is the JITAI group, the one that got the push notifications. The control group is the one who only did self-monitoring. And basically you can see for all of these outcomes, frowny face, caregiver strain, depression, anxiety, no group differences. No group differences here either for caregiver, so we have like, I want to say 12 different outcome measures, and all of our lines look like this, which is really not what you want to see after you've done such a large trial, right? So this was super disappointing. And we were like, well, what happened? Like, why is this happening? And I think one of the first things that came to mind was our control group really a control group? Because they were completing data every day and doing sort of self-monitoring. And we know that in and of itself is an intervention. They use that for weight management and other types of things. When people are paying attention to their symptoms, they behave differently. So that was sort of one thing that we were thinking about as a potential problem with our data set. And we went back and forth, but we figured the best way to sort of tackle this question would be we saw this pattern of behavior when we were about like 2/3 of the way through the study, and nothing was blinded, so we could do analyses at any point. So we knew this was coming, so we opened up a qualitative study where we conducted semi-structured interviews with people in both study arms. And we sort of just asked them questions about their overall impressions. This was really a human-centered study design. So we created sort of examples from their own data of messages they got and their own data dashboards, and sort of talked through it with them to get our caregiver experiences. And what did we find? We found that like the themes didn't differ by the two groups, meaning like we do definitely have an active control group. So that they were both talking about self-monitoring. Both groups are talking about increasing their self-knowledge. There are people in the control group who were telling us how, they were using the Fitbit app in addition to this app to get additional tips and suggestions since they weren't put in the intervention group. They talked about like using the data dashboard information to relieve stress. And both groups had a subset, at least, that talked about lasting changes in behavior due to the intervention. So then we're like, okay, let's think about this now as a multi-component intervention. So we have self-management alone and self-management plus these JITAI push notifications. And so we basically stopped looking for differences between the two groups and wanted to say, okay, did this intervention work for anybody? And if so, who does it work for? So what we found is that regardless of study arm, about a third of the participants got worse, a third stayed the same, and a third got better. And so we were really sort of interested in understanding who got better, right? Like who got better? And we looked at these outcomes in relationship to we had 40 different demographic variables. We had a lot of different baseline assessments. Who is it that's actually responding to this intervention? And what we found is that people who reported that filling out these surveys was easy, that syncing their Fitbit was easy, that answering the questions was easy, people who found that this type of intervention sort of fit into their daily life were more likely to be in that improved group. We also found, which I'm not going to talk about here in depth, that there wasn't sort of one super improver group. So people were improving on different outcomes. So if I was using the intervention and my anxiety might improve, but my physical activity might stay the same, and somebody else might have the opposite pattern of findings. So just because you improved on one domain didn't mean you improved on other domains. So people were using this app and they were improving, but they're improving on different domains of behavior. And this is sort of a graph of our linear regression models for each of the outcomes. This is just creating a figure for 6 months. But basically, finally, we see sort of group differences. So participants with more engagement, and engagement not defined the way you typically think of engagement in mobile health studies. It's defined based on their self-report questions about how well things fit into their routine and how much they liked things at 6 months. But people who were more engaged using that type of definition were more likely to show improvements on our different HRQOL domains, regardless of group assignment. So right, engagement is key. What did we learn? So first of all, we were desperate to get participants through the door. We were on time with our recruitment, which is awesome. But we didn't have any sort of criteria for you had to be depressed or anxious or stressed or experiencing a baseline level of caregiver strain. We only were requiring that they were caring for somebody who had either a complicated, mild, moderate, or severe TBI. And we even know that a lot of times people with complicated, mild TBI don't necessarily need caregivers. So they had to be caring for somebody like this, and they also needed to endorse that they were providing at least some level of assistance, but we had a lot of variability in that question. So, right, first of all, if you're going to look for improvements, you're not going to see improvements if your population isn't distressed. And so I think if we did this again, we would probably set some minimum criteria for some sort of level of distress in terms of this. as I really sort of, I think, went over, like, we didn't think of our self-monitoring group as a control, as we thought of it as a control group, and it really wasn't a control group. People use the dashboard in both groups, and that in and of itself was an intervention. So when we're really looking at efficacy, what we're seeing is that adding the push notifications on top of the self-monitoring didn't really make a difference, right? So it's a little different from this didn't work at all to like we didn't really have a good control group. And then engagement, right? So engagement, we had super high compliance rates, right? Like we paid people, we reminded them, we got data from people every day, but that I don't think translates to engagement. I think compliance and engagement is different. And, you know, this idea of how well it fits into people's routines, like we had so many problems on the app side of things. So like the app would shut down. It would break when, you know, iOS updated their survey platform, or it would break when, you know, daylight savings happened. We had so many app shutdowns, and as the study went on, so we collected data for 4 years, like we got more and more trouble with the app. And so again, this is not a surprise to anyone. If people don't use the intervention, there's no way they're going to get better, right? They might use the intervention and still not get better, but if they don't use the intervention, like the intervention isn't going to help them get better. We had a lot of conversations with an app development team, and we were told, for instance, we were not allowed to get back-end data, like not that we were not allowed to, but that it would be super expensive for us to get just basic usage data on who was clicking on what and how often and how long they were in the app, which I'm not sure why at the time we didn't push back harder. Like I have learned that data is actually not that hard to get, and it's not that expensive to get. They just didn't want to do it, right? We're dealing with a private company who's trying to get this out the door and off their plate. They didn't want to do it. We talked to them at length because we were working also, I work a lot with Sung Choi, and she has an app, and they were having trouble with server space at the time in their study. So they had some shutdowns related to that. So we were like, this is how many participants we're going to have. This is how many participants we're going to have at one time based on our recruitment targets. This is how much data we're going to have. We were very clear about that up front, and we still ended up running out of server space and having to shut down and transfer stuff and figure out a new system. It took us like, I want to say like 12 months to even get it so that we could pull the data down from the cloud because it would time out. So we had a lot of trouble, with the data. Some of that stuff the participants saw because it would result in the app breaking, right? And some of that stuff was sort of on the back end, and we figured it out and then eventually pulled the stuff down later. And so like I think I now know the right questions to ask when doing sort of app development, which I didn't know up front. And even though we tried to sort of explain what our scientific aims were here, and what we needed the app to do functionally, there were breakdowns in communication, and, you know, we were talking in different languages sometimes, and it resulted in some clunkiness in the app. As I mentioned, the app also broke more frequently over time. You know, and these were things like even like daylight savings, and we'd be like, daylight savings is coming up. Do you got, you know, is it going to break? Do you have this figured out? They're like, oh, no problem. And then daylight savings happens and the app breaks and it shuts down. We didn't plan for annual maintenance costs when we put in the budget. I think I got a discount at $15,000 a year, but like, you know, even paying that, we still had frequent shutdowns, and maintenance was most definitely an issue. So, you know, I think one of the things we probably do in the future to overcome that shortcoming would be batch recruitment. And I've seen people who've done this in studies. It's a little harder for us to batch recruitment in these clinical populations, just because, like, when people agree to do a study, if we make them wait too long, they lose interest, right? So we like to enroll people the moment they tell us that they're interested and get them started. Because otherwise, the longer we wait, if we're batching recruitment, the more participants we lose. But in this case, with the app breaking down and things, like, we definitely had much less reliable app service as the study went on. So then in terms of the qualitative study, what we learned about the data dashboard, so I was so excited. So I do a lot of patient-reported outcome measurement development, and I do a lot of like teaching people what is a T-score and what does that mean and how you can use a T-score. It's a standardized score to sort of understand how you're doing. And so we had, we use because I'm like, we're going to use these T-scores on the dashboard. We're going to have this little eye here. And if they click on it, it tells you if a score is like within normal limits, better than normal or worse than normal. So it like explains what the T-score is. But it was complete fail. Participants didn't understand the T-scores. This component of the dashboard didn't make a ton of sense to them. They couldn't figure out like why today my score is a 51 and the next day it was a 49. Like, they didn't understand that. And part of that was that they didn't understand the T-score. Part of that was sort of my cool innovation of let's give a computer adaptive test over the course of a week so people don't see the same items and it's more interesting. But we learned that then we should only be analyzing and looking at weekly T-scores, because the way the computer adaptive test works, it's refining your score over the course of a CAT event. And so looking at any single day, you have different sort of error around that score depending on how many data points you have informing that score. So like mathematically, I guess the long and the short is that like not only did the scores not make sense to them because they're T-scores and they're not intuitive, right? And people don't understand how to interpret data. We didn't do a lot of teaching around that either. But the way we administered the test made these T-scores pretty meaningless. We would have needed to only show them weekly scores for it to sort of make sense and be sort of a reliable measure of what they were experiencing. So that was a big problem. I was super excited because that was one of the more innovative things that we were doing in terms of a measurement piece. And that was an epic fail. Okay, so I just mentioned that. So like the daily score interpretation was meaningless and we couldn't look at day-to-day associations. We can only look at week-to-week associations in our analyses. So in the future, like as much as I love the more sophisticated smart tests, and I think they're super useful, unless you're going to use them as a full CAT event in a single day, reverting to a simple score like a 1 to 10 rating or like some sort of graphic type score is just much more intuitive for people to understand. Okay, so we also heard how some participants, right? So people didn't understand like trends in the data, like what caused it, what do I do to resolve it? So they're like, well, I had a low score this day. Well, I don't remember why. This doesn't make sense to me. And so one of the things that I think in the future, if we can do, would be sort of some sort of notation for participants so that they can sort of make a note for a day that was really crappy. Or, make a note to sort of remind themselves, oh, like this was the day that so-and-so had a really aggressive outburst that I was caring for. And so that's what, that was a very stressful day for me, to help people interpret and understand their own data over time. In terms of the adaptive messages, so this was really a micro-randomized trial and not a full-blown JITAI. And so, it's like when I said I was tired or whatever, the message was saying, if you get tired. So it's not talking to me because I didn't think I wasn't fatigued that day. It's not talking to me. So like the connection, even though we were using their data to inform the notification, that wasn't always successful, right? That connection was breaking down, or maybe they were reporting fatigue, but their fatigue score was in normal limit, so it was giving them a push notification that just didn't make sense for them. And then also, like, depending on when it was pulling the data, we didn't have it pull the data on a week-to-week basis. So if it's pulling it from the self-report data as opposed to the Fitbit data, the T-scores are problematic. So, you know, even though we were super excited about using data to inform what type of prompt they get, people were still getting irrelevant content for them. So in the future, one of the things like we thought of doing is sort of offering a menu for what types of interventions people might want to get, or if dismissing a notification if they don't think it's relevant, or allowing them to opt out of certain message types. If like you're a person who thinks mindfulness is crap and is not going to work for you, like you can opt out of receiving mindfulness messages and sort of at the very least, just select content that you think is more relevant to you. You know, another thing is when the weather is not conducive, you know, it's telling you to walk, go out for a walk and there's like a bad snowstorm outside, right? Or it's telling you to do something, the weather's bad, and, you know, one of our participants said they're not able to remember the suggestion later. There was no sort of way to save notifications if you couldn't act on them immediately. So the timing of the message is important, and maybe we can pull in other app data that allows for like planning or rescheduling or snoozing, or like, I mean, ideally it would also pull in some of the data about your location and maybe the weather, so it doesn't tell you to do something that doesn't make sense because, you know, you have an ice storm outside or whatever. And to add sort of a functionality to, well, we had a thumbs up or a thumbs down rating for people, which we didn't tell them how to use it. We were hoping they would use it to tell us things they liked versus didn't like, but the system wasn't learning from that information, right? So ideally the system would be able to learn if you start a message or favorite a message, so you could either save it for later, and or the system would give you more messages similar to that. Participants didn't adhere to messages that weren't their type of thing. Even when they were told to do something, they might not act on them just because they're not comfortable talking to somebody else about their problems. We have messages that tell them to talk to a friend, and that was really hard for some of our participants because they're like, we don't have any friends. So, you know, sometimes these messages were failing just because they were mismatched with people's motivations in whatever capacity. So again, we're going to focusing on better tailoring of messages can help improve this. And then, you know, the other thing is like sometimes people are doing really well, right? Like I'm already getting exercise, I'm already getting good sleep. Why is it giving me prompts about sleep? You know, I think when I showed you guys some of the examples of the subtle differences between the notifications, instead of telling somebody like you're doing a good job, if you ever have trouble with you should do X, like either not giving them a prompt because they're doing a good job for that domain, or giving them a validation prompt of like keep up the good work, and just keeping it sort of simple, stupid, to avoid this mismatch of I'm already doing well. Like I'm getting 20,000 steps a day. Why is it telling me I need to get more physical activity? So we can do a better job there as well. So we need to make our messages more distinct. And so here's like, again, an example of like a low, medium, and high prompt. They're just too similar. There's not good distinctions here. So I would like the next round, we need to do a better job at making these prompts more distinct, and or not administering prompts for areas where people are already doing well, and focusing more on the things that they need to improve on. Okay, so app development problems. So I mentioned that app developers are not necessarily scientists. The longer your apps around the more problems there are. There are apps that exist out there that you can tailor yourself, right? But they're not, we went with Arbor Moon because we wanted more of a custom look and feel, and there are features in our app that's not currently available through systems like Life Data or Care Evolution or but those sort of off the shelf type platforms don't break as often, right? They're not as adaptable, right? You have to work within their existing framework. So there's limitations there, and they're not as sort of tailorable. You can't have like exactly the look and feel and make it as sort of, I don't want to say pretty, but just sort of customizable in that sort of way. But those type of platforms are less likely to fail over time. So there's sort of a balance between developing something from scratch that has a more custom look and feel and can have more sort of flexible features versus using something off the shelf. So there are trade-offs there. And sort of before I take questions, when I started to work on this talk, my project manager said to me, well, if we did the study again, we'd do it completely differently. So I pulled a quote from Albert Einstein: the measure of intelligence is the ability to change. So there's a lot in here that we need to change and a lot that we need to tweak and work on. And I think what we're doing right now is we're looking at the data, we're continuing to analyze it, and we're thinking about innovative ways that we can I can't take these study results to the NIH and be like, you need to fund phase 2 and cite all the mistakes that we made and all the problems, right? Like nobody's going to want to invest a crap ton of money into another trial for something where we didn't have more favorable efficacy data. So we're sort of taking this as an opportunity to pivot and trying to think of some ways that we can pull in this sort of JITAI push notification into other sort of behavioral self-management interventions with a little bit of a different focus to sort of move the stuff forward. Because I can say with a lot of confidence that there are a lot of good things in this approach, and we did a lot of things wrong. But I still think that these sort of low touch interventions are the way to go for caregivers. And it needs to look and feel differently than what we did, but I think we have a lot of good data here that we can use to create a version that actually would be more effective. We'd also include probably a more traditional control group, which I think would help us as well. But sort of we're just thinking now about next steps and how to move this work forward in light of the disappointing efficacy results for this trial. And these are just our funding sources.